Thank you, Dr. Grusella. I appreciate the introduction. Dr. Kranik, members and guests, it is my pleasure today to review for you what is becoming a revolution, unlike what we've seen for a very long time. And that revolution is that robotics are replacing our standard minimally invasive laparoscopic tools at a rate faster than anybody could have predicted. Here's my disclosure. I'm the co-founder and a stockholder of Virtual Incision Corporation. I also have given some talks for Medtronic and for Stryker. So the United States has all the world's startups concentrated in robotics surgery more than anybody else, if all put together. And the reason for that is because I think the United States market is very, very important for companies, because it's a big market and it's a market that's going to allow innovation, and there's enough capital to sustain that innovation. You may say, well, what kind of robots are coming our way? Well, you saw a number of robots today, but here's some more. This is a slide that Dr. Ankit Patel put together for a robotics course he and I teach. And it's a really good one, because I think it shows you that whether it's hair restoration, ortho, ENT, general surgery, neurosurgery, dental, and on and on and on, are systems that are being either developed or are already approved. We're actually a little bit behind because there have been a number of robotic systems in the ortho area for a long time as well. So we're going to catch up, and I'm going to show you why, I think. So when you look at all of these different robotic systems, and I would love to go through each and every one of them, but there's just not enough time. There's so many. But this is a representative sample. We've heard a little bit about CMR already, and obviously Hugo there on the right, and there are many, many others here, Titan Census and others. What we see is the need to take the straight stick laparoscopic approach and turn it into a digital, robotically enhanced approach. And that's what each of these systems is seeking to do. There are different form factors. You could see that there are robots that have multiple arms, multiple pedestals, robots that are on the floor, robots that are attached to the bed. There are 18 single-port robots in development. There are 82 multi-port robots in development or developed for different applications, including some of the pictures that I showed you earlier. So it's really an incredible explosion of technology that we're seeing. And the value in the end has to be that the patient gets a great outcome through a smaller incision. And then the value to the surgeon is that they have to be able to do it in a way that they feel is reproducible, is safe, and that supports their practice. We talked about the robot, but how do you control the robot? There are a number of consoles out there. We saw the image from a 3D console. You have to have goggles for that if it's an open console. A console where you have an immersion. You can have each eye represent a slightly different view to give you a three-dimensional representation. And then you could see some consoles are open, some consoles are really almost like you're standing next to them. It's amazing, the variety, but they all try to accomplish the same thing. And then there are these emerging platforms, those that I think are really sort of thinking outside of the box. We've heard a little bit about Mira on your right there, and other systems such as human extensions, which is a robot basically in your hand. I think that's a very interesting approach. The Momentus transvaginal robot, the Vicarious system that's being developed, and many others. I can't possibly even represent all of them. There are many out there, all different form factors. So how are we going to take all of these robots and bring them into our hospital? How are we going to teach our surgeons? How are we going to explain it to our patients that this is a new technology, one that's going to change how we provide care for them? Well, new technology is, of course, defined as one which differs significantly for those already listed on a service privileging form or on other requires an additional education and training beyond residency. So as a chair of the Department of Surgery, I often have to decide, does this surgeon have enough training and enough skill to have this privilege? Industry training versus postgraduate training is always a very big question. How do you get surgeons trained up on a new technology? Does the surgeon have privileges already? If they can do an open cholecystectomy, does that mean they can do a robotic cholecystectomy? Do they have to have laparoscopic cholecystectomy privileges? These are questions that have to be solved. Recommendations for minimum training experience that's required, right? You know, our colleagues in gastroenterology keep telling us that unless we are doing 300 colonoscopies, we're not gifted enough to do it. That's in my opinion, probably a way to block us from that craft. And of course, the recommendations for proctoring qualifications and the number of proctored cases. Our hospital, for instance, has a proctoring policy that says any new surgeon has to be proctored for the first anywhere from 2 to 15 cases based on the chair of that department's policies. So proctoring comes in. Why is all of this important? Because if you look at what the Joint Commission says, and then we'll talk about the FDA next, is the expert consensus and a recommendation for robotic surgery. The ECRI Institute included robotic surgery in its top 10 health hazards in 2020. It's off the list this year, but back then, they felt that there were all this unproven surgical robotic procedures. They could put patients to risk. There were all these Joint Commission reports saying that there were problems or sentinel events. And so how do we ensure the safety? Well, they recommend the surgical practice of new technologies. Organizations are required to have specific credentialing policies in place. So basically what they're saying is you, the hospital, bear responsibility to make sure that your surgeons are trained and your patients are safe. The FDA recommends that physicians, hospitals, and facilities that use robotically assisted surgery devices should ensure that proper training is completed and that surgeons have appropriate credentials to perform surgical procedures with these devices. In fact, I could share with you that as part of the MIRA approval by the FDA, a number of tests had to be done to show that the training program was valid and helpful and safe for the surgeon to complete. And so that's an important thing that the FDA asks every industry to do. I'm going to show you some pictures of sort of sensationalism, right? Is robotic surgery safe? In this article, Dr. Schlachter actually defends robotic surgery and says, you know what, in the hands of a trained surgeon, yes, it's safe. And this is a report about, in the Wall Street Journal, about concerns about robotic surgery device. New technology, people both embrace it and then they are afraid that somehow the robot goes awry and something terrible happens. And I think it's important to understand when your patient comes to the hospital or to you, they see this. They understand that there is both a yin and a yang to this new technology. And then, of course, there's ethical considerations. You have to get informed consent. And if the informed consent is, I've only seen this thing one time before, and I've never done one of these, that ought to be part of the discussion. You have to disclose conflict of interest. If the company is paying you to use their device, you should say something to your patients. Transition to acceptance in practice. If it's the first case in the world, there's going to be very, very little acceptance because nobody knows what's going to happen. If it's the 1,000th case, that changes the discussion. And of course, the long-term oversight. You have to audit your surgeons. You have to audit your outcomes. The JCO requires us that we do that through something called OPP or FPP, which is focused practice. So these are all things to think about when you're getting a new technology, these new systems into your hospital. I've always been asked on patient consent, should the surgeon tell the patient this is their first case or second case? And so I'm not a lawyer, so please don't take this as legal advice. But when I did a quick search with the help of one of our excellent experts, Celeste Williams, was here in the audience, we found a number of case law that says basically, yeah, you have to disclose to your patients that you are first time doing this, or have done so few that you may need a proctor in the room. So what does the Urology AUA Society tell us? They've had a lot of experience with robotics, as I'm sure everybody remembers. They were one of the first to adopt that in the United States. What they say is that they think proctoring is an essential mechanism for robot-assisted radical prostatectomy, for credentialing, and as a prerequisite for granting unrestricted privileges. So what they're basically saying is, if you want to do a robotic prostatectomy, you better get an expert to come help you. Then the second thing they say is the implementation of guidelines for proctoring recommendations is necessary to protect surgeons, proctors, institutions, and of course, above all, patients. So what that means, there should be procedures, and we have a very extensive procedure for surgeons that come and proctor on some of the new technology. For instance, we're doing robotic bronchoscopy now, and so it was a very deliberate process to get that technology in and get those cases done safely. Strategies for safety. Well, I think it's important that your OR staff should be well trained and should feel like they are safe in what they're doing. You got to train everybody. You got to train your SPD, which is of course the people that clean your instruments, and your anesthesiologists, so they understand what the issues are. Orthopedics has been doing robotics for a while, and what they've taught us is that you really need to have team training. You can't just train the doc or just the nurse. You got to have team training. And training is not a rigidly defined set of steps, but it's a curriculum that needs to be tailored to the individual. We certainly, in robotic bronchoscopy, spent some extra time because we felt that there were some glitches that we wanted to iron out before we went live clinically. And then multiple platforms are coming our way. Are they going to confuse the surgeons? Are they going to confuse the patients? And I think the answer to that question is competition is going to help us land a better, safer robotic system, robotic platforms. I think the tide will float all boats. And so here's what virtual incisions approach is. We're going to create a technology and workflows that are instinctive to the surgical team. And we have data to support that because of doing human factors testing and working with a human factors engineering. We're going to create and validate a training program that is individually tailored to the user and has meaningful competency-based milestones. This program is already in existence and had to be in existence before FDA would give us a permission. You got to support not just the technology, but also the surgeon with proctoring. So you got to have experts that are going to come and help you. And you have to collect post-market clinical data to continually improve. The FDA requires it, but I would argue as surgeons, we should all know our outcomes, and we should always strive to do better. And of course, virtual incision feels strongly, and I feel strongly, that we should continue to innovate. We can never stop innovating. So in conclusion, new robotic technology is coming to a hospital near you. Safeguards, including credentialing, privileging, and maintenance of privileges, should be in place at that hospital, and it should be done in partnership with hospitals, surgeons, and industry. Each technology will require a needs assessment. Individual hospitals and surgeons will require tailoring their training because everybody does something differently and everybody comes from a different place in their skill set. And mentoring and proctoring is essential for new technology implementation. I know I've said that a bunch of times, but I will tell you how important that is to have an experienced surgeon standing over your shoulder to help you on your first try. Thank you.